बात कर रही हूँ कंप्लेंट डिपार्टमेंट से, राणा मोटर्स जहांगीरपुरी।
सर फिर कल आना है,
बात कर लेंगे शाम को।
ठीक फिर सर मिला
उनको बोल दियो आएंगे चाय देने तो दे जाएंगे तरीके से
हाँ
आके ना, गेट में ज़्यादा हल्ला ना करें। Hi everyone, I hope my voice is clear. The audio video both are fine. So just waiting for some time so that I can get some confirmation. So hello to all our students of TND batch 2024 and to all those who are watching me live on our YouTube channel. Yeah, so today we are here to discuss the test and discussion of orthopedics. All right. Hi Sai, how you are doing? Okay. So good evening. Okay. So Sai, you have been in our regular batch as well. If I'm not wrong, you have been there and you have been preparing very, very well. So great. So we are ready to start with our TND. All right. So I hope that everybody has got the paper, the question paper of orthopedics, and we have here jumbled up question of different topics. And I'll try to revise whole orthopedics in this session of the fast track TND we have. The question paper. I hope we are ready to start and let's go ahead now. Let's start with the paper. All right. So number one, the first question we have here, it is asking about the preferred treatment of a displaced transverse fracture of the patella. Now, question is very simple. Answer, I'm sure each one of you very well. But what was the purpose of giving you this question? So first of all, it's a repeat question of the NEET exam 2018, 19 and 20. All the 3 years it was there in your exam, right? Second important thing, yeah, beat the next batch. You were there. So the second thing is this question is telling you something that there are certain injuries which can't be conserved. You can't treat them without operating them, right? So all the time you have to go for the surgical fixation. Okay. So very first one, displaced transverse fracture of the patella. So whenever there is a fracture of patella, we know that patella being the sesamoid bone into the tendon of quadriceps, it has got the muscles attached to it. It is the quadriceps here, the lower part ligamentum patelli here. That is how it is. Okay. And okay. Yeah. All right. So this is how the quadriceps is actually, right? Now, whenever the two-part fracture of patella has happened, you know that these two will be pulled away from each other, because of these distractions by the fibers. Okay, that is the reason, again, we have to put two K-wires here. We have to put a K-wire here. We have to put a K-wire here. And then we tie them by the stainless steel wire like this in the figure of fashion. Now, this is the surgery, what we are calling as the tension band wiring, right? So what are all those injuries which require fixation all the time? What are those injuries where you don't have to answer that conservative is my plan? Okay, so I'll just explain that. So what we are going to do during the course of this class, we are going to make certain tables, right? I'll make certain tables, and these tables will be the compilation of multiple topics brought together, multiple injuries brought together, which will have multiple n number of MCQs for us. All right. So let's start making certain tables or certain points. The point number one, I'm starting with the point one. The point number one is all about, the point number one is all about the fractures which require surgical intervention all the time. And what do we call them? The fractures of necessities, right? The fractures of necessities. So let's understand this. When you talk of the fracture of necessities, there are three most important injuries which we must never forget. What are those? Number one is the fracture lateral condyle of the humerus. The fracture lateral condyle of humerus is the first fracture of necessity. And why is that a fracture of necessity? Because of simple reason that there has to be an extensor tendon pull all the time. So lateral condyle of humerus, it will require fixation all the time, right? That is number one. Second one would be the fracture Galeazzi. Galeazzi is also a fracture of necessity. Reason being, there is a fracture of radius bone only and ulna is intact. So you can't pull the ulna to bring the radius back into the position as the length of ulna is maintained. And number third is the fracture neck of the femur. It is the fracture neck of the femur. So these three cases are always and always the fractures of necessities in all 100% cases, right? In all 100% cases. So all the cases of lateral condyle, all the cases of Galeazzi, and all the cases of neck femur are ideally supposed to be fixed. But then there are other fractures of necessities as well. What are the other fractures of necessities? What are the other fracture of necessities? Other fracture of necessities are, number one, there can be a two-part fracture of patella. A two-part fracture of patella, right? Two-part fracture patella. Second, it can be a two-part fracture of olecranon. Two-part fracture of olecranon. There can be, number three, any displaced intra-articular fracture. Displaced intra-articular fracture. Number four, when the displaced intra-articular fractures are always requiring an open reduction. Example I can put here, displaced intra-articular fractures. The example, they are Barton's fracture. Remember, the Barton's fracture, Bennett fracture, there can be Rolando fracture. So they always require fixation because they're intra-articular injuries and they're getting displaced, right? And number five, the classical montage, the number four actually here, the classical montagia, right? Not all the montagias, but the classical montagias. Not all the montagias, but classical montagias are the fractures of necessities. Okay. What is a classical montagia? Fracture of proximal 1/3 of ulna with dislocation of the proximal radioulnar joint, right? With dislocation of proximal radioulnar joint. Now see, these are those injuries where there is a condition related to them. And what is that condition? The condition is the fracture of patella when it is happening in two parts. Not every fracture of patella will require a surgical fixation. Not every fracture will require a surgical fixation. Like undisplaced fracture, they don't require a fixation. But when it is two-part, it is going to require a fixation. And that is why these are all the fractures. These are all the fractures with a condition, which are also called as the fracture of necessity. So what is a condition? When it is a two-part of patella, when it is a two-part of olecranon, when it is a displaced intra-articular fracture, and when it is a classical montagia. So these are all fractures of necessities. I hope this is clear to everyone. Yeah, correct. It is Bennett, Rolando, Barton's. These are all fractures of necessities. Okay, that is question number one. So one table, the point number one we have made is about the fractures of necessities. Let's talk about the other one as well. Which of these statement is wrong about the condition shown in the image? What do we see in this image? What is the deformity the child is having? Now, when you look at the image here, the foot is getting broken here into the midfoot area, right? This is a midfoot which is showing us a break in the foot, a midfoot which is breaking in the foot area, right? Now, when you look at this, we know that we are talking about a patient of CTEV, the congenital talipes equinovarus. That is how the CTEV will look like. Now, what is the question asking you? Which of these statements is wrong? Which of these statement is wrong, right? So the first deformity to be corrected in CTEV is what? Cavus? Yes, it is cavus. The sequence of event, when you correct the deformity, the sequence of correction has to be which one? We know that it has to be cave, right? What does that cave stands for? The first deformity to be corrected in the cases of CTEV, it has to be the cavus, the deformity which is very much visible in the image as well, followed by adduction, followed by adduction, followed by varus, and followed by equinus. Okay, so cavus, adduction, varus, and equinus, that is the sequence we have. All right, the correction assessment can be assessed by the Pirani scoring. True, that is also correct. Pirani scoring, when you are giving the plaster, you know that the score has to go down. If it is going down, the plaster is able to give you the correction. Kite's angle will be increased. What is that kite's angle? Kite is the angle between the talus and the calcaneum. The kite angle, when you talk about that, it is the angle between the talus and calcaneum. You remember how much is the normal angle between the talus? If it is my right foot, right talus, right calcaneum, how much is the normal angle? You see it from the front, you see it from the top, see it from the lateral. It is having a very big range, 25 to 55 degrees. Now in CTEV, you know that talus goes so into medial deviation. Calcaneum also goes into medial deviation. So when they go medially, the axis of both the bones are parallel. Now the angle is 0. So kite angle doesn't increase, it actually decreases. So this statement is wrong, right? The third statement is wrong. And Dennis-Brown splint is used after the correction is achieved. That is true. Once the correction is achieved, we are going to give the Dennis-Brown splint initially 3 months for the full time period. And once the child starts walking, after that only in the night time. So statement number 4 is also okay. So answer is option C, which is a wrong statement. The angle kites will be reduced. Now angles, when you talk about the angles here, this is one angle, the kite angle. What are the different angles we know, the named angles? So point number 2 I'm giving you here. Point number 2 I'm giving you here is about the different angles used in normal routine studies when you're preparing for PGME. So angles, the named angles, okay, that we can learn here. What are the different named angles? So different named angles can be one, the first one of our question itself, that is a kite's angle. Kite is an angle used for what condition? It is for CTEV. CTEV, that is the talus and calcaneum. That is talocalcaneal angle, right? That is a talocalcaneal angle. That is kite's angle. Number 2, starting from the elbow area, what is the angle we have in elbow area? It is called as Bowman's angle. Why do we use Bowman's angle? For what condition? When you have to reduce the fracture supracondylar humerus, right? So it is seen in the elbow area definitely. That is the other named angle, the Bowman's. Then we have angle number 3, Cobb's. Then we have the angle number 3, that is Cobb's, right? So we have Cobb's angle. We have Cobb's. Where do we see Cobb's? Cobb's is for scoliosis, right? Cobb's is for scoliosis. Then we have another named angle where in the calcaneum area, you remember the angle Bowler's and the crucial angle of Gisane. Where do we see these two angles? These two angles are seen in calcaneum. These two angles are seen in calcaneum, right? And in the foot, we have another angle called as Mere. Remember, Mere angle. Why do we see that Mere angle? For what condition do we see that? Mere is between the first metatarsal and talus. First metatarsal and talus, that is in the lateral view, right? And that is telling us about what? How much is the normal angle there? 1 degrees to 4 degrees. And if the angle now is decreasing, it is becoming 0. What do we call it? The flat foot. So to check here for the flat foot or to check here for the cavus deformity, we can have a word about the Mere's angle. So kite, Bowman, Cobb's, Bowler's, Gisane, Mere. These are 6 named angles with which we should be very familiar with. Yeah, for the supracondylar. Okay, so this is how you have a table about the different named angles. Now, if you're going for INI set exam, you know that in INI they can ask you different types of questions. One of them can be matching side A with side B. So now when you have the names of these angles, they can very well ask you, like Cobb's has been a question of previous years of the INI exam. They gave you the angle and they asked you, where do you use it? So Cobb's angle is for scoliosis. All right, that is your question number 2. Number 3, the shown test is done for the compression of, okay, what is the so we have an image over here, and what is getting compressed, what structure will be getting compressed here to look at this structure. So you can see the person hands are like that and he's trying to like open and close the finger. What test are we talking about? You know very well that we are talking about the Roos test. We are talking about the Roos test. Okay, why are we doing it? Roos test, it is to assess the subclavian vessel compression. Now the test in orthopedics, they have been repeatedly asked in all your previously conducted exams, right? How they've asked the test, what all tests can be done. So I can give you one simple table of all the tests being like conducted. So point number 3 is about the different clinical tests which can be learned, which can be like remembered here. So the number 3, the clinical tests. Number 3 is clinical test. Okay, the different clinical test. What are the different clinical tests we have? What are the different clinical tests we have? So I can just give you the list of different clinical tests. I can just give you the list of different clinical tests all at a place, right? All at a place, right? So clinical test starting from the upper limb, going to the shoulder, going to the back, going to the lower limb like that. When you look at these tests, okay, when you look at these tests, yeah, what all we can see from the top to the bottom, what all we can see from top to bottom, what all tests we have, what all tests we know. So starting from the hand area, number 1, the first one in the hand itself, starting from the hand, the first test that can be done is ask the patient to keep the thumb in the fist and go for ulnar deviation, starting from the hand here, thumb in the fist and going for the hand like this. What is that test called as? So first test, the clinical test is called as Eickhoff test. First test is here, the Eickhoff test. Now what is that Eickhoff test for? Eickhoff test, you know that it is for the inflammation at the base of the thumb. That is the decurvens tenosynovitis, right? That is for decurvens tenosynovitis, right? That will be decurvens tenosynovitis. All right, number 1. The other name, the other test which can be done at the same site, it has to be the Finkelstein, right? It has to be the Finkelstein test. It has to be the Finkelstein test. Okay, Finkelstein is just simply ask the patient to keep the hand like this and you pull the thumb. That is Finkelstein test. Okay, Eickhoff. Number 1 is Eickhoff. Test number 2 that can be done at the same site is for the inflammatory, like, or you can say you can ask the patient to keep the elbow flexed and extend the wrist against some resistance. Now this test is called as what? The second test will be Cozen test. Second test is Cozen test. In the hand area, we can go for Cozen test. What exactly are we doing here? The Cozen test is done for the lateral epicondylitis. The second one is done for lateral epicondylitis, right? Second one, lateral epicondylitis. Third test at the same site that can be done. The third test which can be done at the same site is the one which you do for the compressive neuropathy here. And what is the nerve over here? The nerve is the median nerve. And what is the test, the most sensitive test we do? So there are so many. What are those? Number 1 is Durkan's. Number 1 is Durkan's test. Number 2 is Fallon's test. Number 3 is Tennell's sign. Number 4 is tourniquet test. These are all the tests which are done for the compressive neuropathy at the wrist area. For what structure? It is for the median nerve. And this simply is called as what? The carpal tunnel syndrome. This simply is called as what? The carpal tunnel syndrome. Right? That would be the carpal tunnel syndrome. All right. So, right. So that is the carpal tunnel syndrome we are talking about. Carpal tunnel syndrome. Right? That is behind me now. Okay, so list, I hope this list will be very, very useful. So now when you talk about the angles, these are the angles, the fracture of necessities, and this third one, the clinical test. Okay, so Durkan's, Fallon's, and tourniquet. And in the Durkan's, we should know that this is the most sensitive test. This is the most sensitive test for carpal tunnel syndrome. This is the most sensitive test for the carpal tunnel syndrome, where you ask the patient to just compress. Examiner is going to compress upon the wrist of the patient, right? Number four, we go a little up, and the test which can be done after these three is one around the shoulder area, and the name of the test is lift off test. You remember why the lift off test is done? You ask the patient to keep the hand on the lower back, okay, and ask him to lift against some resistance. So this lift off test is done for which muscle? Power of which muscle? It is subscapularis. It is subscapularis. The strength, the power of subscap. That is why it is required. The subscapularis lift off test. Number five is we talk about the spinal area. We talk about the spinal area. What are the named clinical tests at all the spinal segments? So we start from the upper area, going to all the length of the spine. So in the spine, there is one test called as the Adams test. You remember that? Why the Adams test is done? Adams is done to differentiate between the physiological and the pathological scoliosis. Okay, it is done to know or to see the pathological scoliosis basically. Okay, physiological or pathological one. So pathological scoliosis versus physiological scoliosis. Okay, ask the patient to stand straight and flex forward. So physiological versus, or postural, I should say, there is nothing called as a physiological one actually, it is a postural one. So postural versus the pathological scoliosis. Ask the patient to stand straight and bend forward. Ask the patient to stand straight and bend forward. On forward bending, the postural one, the scoliosis which is not there is not going to stay, and therefore the pathological, it is going to stay. This is what makes the difference. Adams test. Number 6 in the spine is what we call the modified Schauber's test. It is called as the modified Schauber's test. Now what is that modified Schauber's test? Why are we doing it? Modified Schauber's is done for the mobility restriction of lumbar spine. It is done for the mobility restriction of lumbar spine. Number 7, in the sacroiliac joint. For the sacroiliac joint, what are the clinical tests that can be done? For sacroiliac joint, you remember, this is the first joint to be involved in ankylosing spondylitis, and therefore the inflammation change has to be seen here, right? So the first one is called as Ganselin's test, or the other one here we have is pump handle test. So Ganselin test or the pump handle test. Ganselin or the pump handle test, that is sacroiliac joint. Then we have around the hip joint. In the hip joint, what are the different names, these name tests? When you talk about hip, the most important name test is in relation to congenital dislocation of the hip. What are the different name tests here? One, the first one to be done in any newborn baby, it is a Alice test. It is a Ellis test. Second one, it is Barlow's test, Ellis test, Barlow's test, or the third one is Ortoloni test. It is Ortoloni test. So Ellis, Barlow's, and Ortoloni test. These are 3 tests to be done in any newborn baby, right? So this is the hip area. The knee test, coming onto the knee region. Coming onto the knee. In the knee, what are the different name tests? We know that one is the test for menisci. One test is for menisci. What are the name tests here for the menisci? One is McMurray's. The first one has to be McMurray's, and second one has to be the Epley's grinding test. McMurray's or Epley's grinding test, right? That is another list we have. Then we have another set of structure here, cruciates. Then we have the cruciates, and in the cruciates, what are the important clinical tests we know? Acute cases. For acute cases of the cruciate injury, the test to be done is Lashman, because Lashman requires how much flexion of the knee? 20 degrees. And overall, in normal regular cases, what we can do is drawer test. Now this drawer test, it can be anterior drawer or it can be posterior drawer. This is done with the knee flexed at 90 degrees, right? Meniscus and cruciates. Okay. After that, when you go down further in the ankle region for the Achilles tendon, rupture of Achilles tendon, what is a clinical test which can be done? It is Thompson test. That is Thompson test. So these are the different tests which can be done at different areas, right? So name some of the name tests which can be asked if you just see from them. This one, the Durkin, has been the INI exam question itself. All right. So these are different ones. McMurray's, Epley's are the common ones to be done. So this is your point number 3, the different clinical test just summarized at one place. All right. Yeah, this is fine, I believe. Oh. Just give me a moment. I think I have lost the group somewhere. Let me just see where is a group. Yeah, here it is. All right. So I hope it is going fine. Aikov. Yeah, all fine. Akash, thank you for confirming. Now, those who are watching me live, I can't see your reactions here, what you're putting in the live chat. I'm not able to see that. Let me just figure it out. Okay. So coming on to the next question we have. Bowler's angle. We have just talked about the bowler's angle and the angle of Gissane. They are seen where? They are seen in the cases of calcaneum bone. Okay. Compartment syndrome, a very, very important topic and has been asked kind of number of times in the previous years. Okay. Compartment syndrome, you know very well that there are so many questions which we often keep on discussing with each other. Pulse, parallel, this paralysis, pulselessness. Now, which one comes at what level? Okay. So first of all, let's have a few words about the compartment syndrome. You know that compartment syndrome, certain points about the compartment syndrome. So this is number point 4, I would say. This is point number 4, which is about the compartment syndrome. Okay, it is compartment syndrome. Now, in compartment syndrome, we should know a few things. What are those things? Number 1, above what pressure do we say that the pressure in the compartment is going to be lethal for the soft tissues? When the pressure is more than 30 millimeters of mercury. When the pressure is more than 30 millimeters of mercury. Okay, second point here about the compartment syndrome, which is the bone, the commonest fracture to develop quickest, the compartment syndrome. So the most commonest one is the fracture diaphysis of tibia. Second one is fracture diaphysis of tibia, right? Third one, which is the most commonest muscle to get involved in compartment syndrome? So most commonest muscle to get involved in compartment syndrome is FDP. Which is the most commonest nerve to get involved in compartment syndrome? It is the anterior interosseous nerve, which is involved most commonly in which fracture? In supracondylar humerus. Number 5, what is the first symptom of compartment syndrome? What is the first symptom of compartment syndrome? It has to be pain. What is the first sign of compartment syndrome? Again, it is pain, but on passive stretch. So pain on passive stretch is the second commonest, or you can say the first sign to be seen, the pain on passive stretch. Number 7, pain on passive stretch is about the pulse. So please note that pulse is not a reliable indicator for compartment syndrome, and the pulselessness, the absence of the pulse, it is actually a late feature in compartment syndrome. As a part of the treatment, what are we supposed to do in compartment syndrome? It has to be fasciotomy, right? Which fascia we should cut? Only the superficial one, or deep also is required? So all the time it has to be superficial as well as deep. In the previous years, when this question has been asked in the last 4 or 5 years, the one of the question has been the site, one has been in relation to pain on passive stretch, and one has been in relation to the structures which are resected if there is a compartment syndrome, right? So these are 3 the important questions which have been asked. Point number 4, compartment syndrome. So what is our question here? What is our question here? They're asking you, compartment syndrome is most common following the fractures of which area? So it is fracture of the diaphysis of tibia. The fracture of diaphysis of tibia. All right, that is number 5. Perfect. Okay. The number six. Number six is a very, very important question. Very, very important one. 35-year-old male was riding a bicycle and he got hit by a vehicle coming from the front. He got the attitude of the right hip as shown here, adducted and internally rotated. What is the most likely diagnosis? What is the most likely diagnosis? What do you suggest? The hip here is turned internally. It is close to the midline of the body. That is adduction and internal rotation. All right, that is adduction and internal rotation. Where do we see that? Person was riding a bicycle. What is the relevance of this history here? When you are riding a bicycle, we know that the patient has to have his hip and knee flexed. Now, when the hip and knee is flexed, and if there is an impact onto the front of the knee, what will happen? The impact goes to the thigh, from the thigh to the neck of femur, neck to the head of femur, and it perforates the socket and goes back. That is in the gluteal area. What are we talking about? It is all about the head going back, and that is in favor of what? The posterior dislocation. That is in favor of posterior dislocation, right? So attitude is the key to reach to all the diagnosis, all the diseases, all the disorders around the hip area. Attitude is going to change the answer, right? That's very, very important. So there is one very important table I'm going to make now for you. It is about the attitudes of the hip in various conditions. And by the means of this table only, we are going to revise so many topics. Let's make that. So point number 5 now. The point number 5 is about the attitude of the hip. Point number 5 is about the attitude of the hip. So point number 5 is about the attitude of the hip. Attitude of the hip. So attitudes, in which all condition, what all kind of attitude can be seen? In which all conditions, what all kind of attitudes can be seen? The attitudes of hip. Yeah, dashboard injury. Yes, you're right, Sai. Absolutely correct. Attitude of hip. Could you please send the images of test? Why not? I can send the images of the test. Not to worry. I'll share in the group. Okay. See, what all conditions will bring what kind of attitude of the hip? What all conditions will bring what all kind of attitude of the hip? Okay. So first on this side, I'm writing it as the attitude of the hip, the attitude, how the patient is coming to us, the attitude, and what is the probable condition. Attitude and probable condition. Okay, let's see how we can do the mix and match in that. Attitude and probable condition. How do we learn these things? See, the first attitude I'm putting here, the first one, it has to be like, let's suppose a patient comes to you with abduction and external rotation. A patient comes to you with the attitude of abduction and external rotation. Okay, what all he might be suffering from? Abduction and external rotation. What all he might be suffering from? So, abduction, external rotation, it can be seen in variable, conditions. Number one, abduction and external rotation, keeping the hip away and out, where all we can see this abduction, external rotation. It can be seen in anterior dislocation of the hip. It can be seen in anterior dislocation of hip, right? Anterior dislocation of the hip. In the anterior dislocation of the hip has to go like that only, like abduction, external rotation. Then only the head of femur can come out. That is number one. Second one, where we can see the abduction, external rotation. Where do we see that? In any condition which is related to synovitis. In any condition which is related to synovitis. Now, what all can be related to synovitis? What all can be related to synovitis? Let's talk about that. So, synovitis, it can be seen, number one, in the first stage of tuberculosis. Synovitis can be seen in the first stage of tuberculosis. What is the first stage of TB? We know that the first stage of tuberculosis has to be synovitis, right? The first stage of TB has to be synovitis. So, abduction and external rotation. Other condition where we can see synovitis only. Other condition where we can see synovitis only is septic arthritis, right? It is septic arthritis. Now, what is the basic difference between these two, the tuberculosis and the septic arthritis? You know very well that the tuberculosis, when it goes to the hip joint, when it occurs in the hip joint, the most commonest foci in tuberculosis of the hip joint is where? It is in acetabulum. The most commonest foci is in acetabulum. But on the other hand, the most commonest foci for septic arthritis has to be where? The most common foci in septic arthritis has to be where? The head of femur. That is epiphysis actually, because you know septic arthritis, it occurs most often in the smaller kids, 2 to 5 years. It occurs in a child of 2 to 5 years. So when it occurs in a child of 2 to 5, we simply call it a septic arthritis, but sometime it can happen in a child less than 1 as well. Whenever it is occurring in a child less than 1 year, what is the fancy name? What is the entity it is called as? The Tom Smith arthritis, right? It will be Tom Smith arthritis, right? So tuberculosis and septic arthritis, it simply means that it is an organism which is like staph, staphylo, pseudomonal, fungal, like that. When it is mycobacterium tuberculosis, it affects the acidulum first. When it is a basic organism, it affects the head of the femur first. Okay, so anterior dislocation and the synovitis. Any other condition where we see synovitis? You remember synovitis? Third condition where we can see synovitis is transient synovitis. Transient synovitis. Now, what is a transient synovitis? Transient synovitis is a synovial inflammation for a transient period. And how does that present? Transient synovitis comes up in a child between 5 years to 10 years or 12 years, broadly like that. And what is a typical history we have here? It is the history of upper respiratory tract infection, URTI. So URTI is basically the most commonest complaint which the child will be having in the recent past, after which the pain starts around the hip area, right? So transient synovitis. What else can produce or present as the synovitis? It is the first stage of Perthes disease. It is the first stage of Perthes disease, right? It is the Perthes disease. Overall septic arthritis, the most commonest is knee joint. See, there is no actual reference to tell you that it is the knee joint. If you see clinically, if I tell you my clinical practice, yes, it is more commonly seen in the pediatric age group in the knee. But yes, there are certain literature which are telling that the most often the septic arthritis happens in two joints, hip or the knee. And the difference in presentation of hip and knee is 48% cases occurs in hip, 47% occurs in knee, and remaining 5% it occurs in rest of the joints. So hip and knee broadly are affected in equal numbers. Hip and knee broadly are affected in equal numbers, or you can say equal proportion. Okay, so there is no reference like that. So Perthes disease, the first stage has to be synovitis. So all of them will be coming to you with abduction and external rotation only. That is number one. Number two is adduction and internal rotation. Number two is adduction and internal rotation. Where do we see adduction and internal rotation? Adduction and internal rotation, the hip is being kept close to the joint. The hip is being kept close to the joint. Yeah, okay. All right. So adduction and internal rotation, where do we see? Number one, it can be seen in the cases of posterior dislocation of hip. So posterior dislocation of hip, it usually comes up with the adduction and internal rotation, right? Adduction and internal rotation. Where else we can see the adduction and internal rotation? This will be seen in further stages of tuberculosis. Adduction internal rotation will be seen in further stages of tuberculosis. Now that will be the second stage of TB. What do we call that second stage of TB? Second stage is early arthritis. Second stage is early arthritis. Third stage is the one which is late arthritis, or the fourth stage, the final stage, which is advanced arthritis. Now, how do you make a difference in all the stages of tuberculosis? How do you make the difference? So first stage of TB is always the synovitis, right? Synovitis comes up with abduction, external rotation. In the adducted and internally rotated attitude of the hip, early arthritis, the late arthritis and advanced arthritis, what are the typical features that can be seen? Early arthritis on X-ray comes up with periarticular osteopenia. It comes up with what feature? We know it is a periarticular osteopenia. That is periarticular osteopenia. Number two, late arthritis. Late arthritis means now there is a decrease or loss of what? Of the joint space. Decrease or loss of the joint space. And advanced arthritis is the one where we see one very, very classical feature. in TB hip. And what is that? Wandering acetabulum. Remember that? Wandering acetabulum. So periarticular osteopenia, stage 2. The blackening around the joint surface, joint space is lost, is stage 3, and wandering acetabulum is stage 4. So adduction and internal rotation. Then there can be sometime the third attitude. Then there can be third attitude sometime, and that is adducted hip, but it is externally rotated. Adducted hip, but it is externally rotated. And where do we see that? Adducted hip, but externally rotated. Number 1, it can be seen in Perthes disease. It can be seen in Perthes disease. Perthes disease, the first stage is synovitis. So abduction, external rotation. Next would be necrosis, and that comes with this one. So necrosis stage of Perthes will come up with adduction and external rotation. After that, we have another condition as SCFE, right? Slipped capital femoral epiphysis. That will again come with adduction and the external rotation attitude. Now, what is the difference in these two? Perthes disease is a condition which is seen at the age of 4 to 8 years, and most commonest etiology is trauma, which is a recent past trauma. Okay, so recent past trauma of the hip area. Recent past trauma of the hip area. SCFE on the other hand is a slip of the capital femoral epiphysis, right? And this occurs in the adolescent age group, that is 10 years to 15 years. 10 years to 15 years, that is SCFE. And this condition, basically, it can occur as an acute trauma. So SCFE will have an acute episode. Today morning he fell down and he started having this hip in adduction and external rotation. But in Perthes, it has to be a history of recent trauma, not today, not immediate, but in the recent past, it has happened. Okay, and that impact on the head of femur has brought the inflammation. That is Perthes disease. Something more can be learned from this table as well, right? Whenever there is abduction deformity of the hip, we know that there has to be limb lengthening. There has to be limb lengthening, right? There will be limb lengthening. Okay, and this limb lengthening, we know that it can be true or it can be apparent. So in this anterior dislocation, it has to be a true lengthening. In the stage of synovitis, it has to be an apparent lengthening, right? When you talk about adduction attitude, adduction always brings shortening. Adduction always brings shortening. Now again, this shortening can be true or this shortening can be apparent. Okay, this shortening here in the posterior dislocation, it has to be a true one, because the head of femur is losing the socket, it is losing the articulation. In early arthritis, as there is no joint destruction, this shortening again has to be apparent one, right? But in the stage of late arthritis or in the stage of advanced arthritis, it again gets shortened. So it has to be true shortening and true shortening, right? So shortening with adduction and abduction leading to limb lengthening. Abduction leading to limb lengthening. Okay, so abduction, external rotation, adduction and internal rotation. Okay, is this table fine with everyone? The students on YouTube, the students on DBMCI live app, are you all okay with that? Akash is there, Sai is there. Okay, so everyone. So Devyaksh, Mohit, I can see you all there. Okay, fine. Right, great. So shall we proceed? So this was your question number which one? So point number 5. Point number 5 has given you so many questions, and even TB you have read here, right? So TB stages are already revised. So this was your question number which one? This was your question number 6. Okay. Now coming on to 7. Denosumab. Shall we make some more tables like that, or would you like to discuss like question by question? If you can please tell me that. Sai, Akash, rest of the people, guys, how would you like to continue? Shall we make some more tables or shall we go question by question? Whatever way you are comfortable, we can go like that. So I'll just wait for a few seconds, whatever way you are comfortable. So denosumab, meanwhile, it is a one-liner, and you know very well that denosumab is used where? In the cases of osteoporosis. And how it works? It blocks the rank ligands, right? It blocks the rank ligand. And what the rank ligand has to do? They will be activating the osteoclast, right? So this denosumab, it blocks the rank ligands. Okay, it blocks the, yeah, great. It blocks the rank ligand. All right. So this is how denosumab actually works. Okay, fine. Number 8 is about the first to be affected in rheumatoid arthritis. What is getting first affected in rheumatoid arthritis? Okay. So what do you suggest? What first gets affected in rheumatoid arthritis? What first gets affected in rheumatoid arthritis? It is the synovial membrane. And when you talk about the cartilage, it is first getting affected in osteoarthritis, right? It is getting first affected in osteoarthritis. So OA primarily involves cartilage. RA primarily involves synovium, which later involves the bones. Okay, that is how it is happening. So all the deformities of rheumatoid, which we are going to see some more questions here, why they happen, the primary defect always and always has to be the synovial inflammation, right? Primary defect has to be always the synovial inflammation, right? Number 9, the test being done for Achilles tendon. The test being done for Achilles tendon. What is the test being done here? The person, examiner, is squeezing the calf of the patient. We know that there is a gastrocsoleus complex, and this gastrocsoleus complex, it is making the tendoachilles here, right? This tendoachilles, when you are squeezing the calf, okay, right. So when you squeeze the calf, if the tendoachilles is intact, what will happen? The foot will go into plantar flexion like this, right? The foot goes into plantar flexion like this. Okay. Now, if the tendoachilles, let's suppose by chance, is ruptured, it is not intact, it is ruptured. When you squeeze the calf, what's going to happen? When you squeeze the calf, the foot remains on the position. What is that called as? You've already made the list, and this is called as Thompson test, right? One very, very important test we'll just see, I have like not written that in the list, is Thomas, because I want to show you how the Thomas actually is done, and it has to be learned separately as well. So there is one other question I'm going to discuss with you in a while, right? So this is the Thompson test. Then we have the number 10, the scoring system used to know further deterioration in the further progression of scoliosis in a child. So question is asking you, a child is suffering from scoliosis. Okay, a child is suffering from scoliosis, and how will you know that there is further still possibility of progression of the scoliosis? What do you suggest? What do you think? So it has to be the Rizer's grading. And what are we doing in Rizer's grading? We check for the x-rays of the pelvic area, that is iliac crest. If the iliac crest is completely developed, it coincides with the development of the spine, the vertebra. And if the iliac crest is showing you the growth plate, it is not completely developed, that simply means that the growth of the vertebra is still pending. Okay, so if the growth of vertebra has not happened, that means there is further possibility of deterioration of the spine. This is what is being told by Rizer's. Glasgow Coma Scale, this is, it's for the neurological status of the patient, right? We know that it is for neurological status of patient. Salter-Harris injury, it is for physial injury or the physial trauma. And Gartland classification, it is for fracture supracondylar humerus, right? The fracture supracondylar humerus. So these are different ones, the different classifications for different areas or the different terminologies. Okay, so yeah, this is number 10. Another very, very interesting one. Okay, fine. So now we are gonna change the link here, guys. It has been on YouTube like for an hour or so now. So now you all can come into this DBMCI live, and I'll be just taking the class there itself. Okay, so just hold on for a few minutes, maybe like 2-3 minutes only, and I'll be live again with the change in the link, and the class will now be relayed only onto the app. So if you're outside the app, please be in the app and you can just continue with the class. Okay, so just hold on for a while and it will be done in a moment.